Hi, everybody. I would like to start the webinar of today with this couple of welcome and words and brief introduction to the subject we're going to have this webinar on. And I think really the subject is fascinating. Recalcitrant urticaria. When we give lectures on urticaria, there's always somebody in the audience telling, okay, but what do I do when I already did everything and my patient still doesn't get better? What to do when the guidelines fail? I'm really so thrilled that we can start this webinar of the new year 2024 with exactly this difficult subject. And yeah, sure. And even better, we have an amazing group of faculty together with us today, starting, myself. I'm Désirée Larenas-Linnemann from Mexico City, where I work and live. And joining us here is Professor David Ken. He is from the University of Texas, Southwestern Middle Center, Dallas, and he's ex-president of the QuarAI, so a very strong person in the world of drug allergy and urticaria. Dave, we're so happy to have you here with us. Below me, you can see here Professor Jorge Sanchez. Professor Jorge Sanchez is one of the leaders in Colombia on all the thoughts of urticaria, doing some research as well, has published quite a lot on urticaria, and really happy he is head of a training center there in Medellin, really happy to have him on board with us today. And as you can see, this is really a global issue because I'm here now in the Netherlands. David Ken is in US. Professor Jorge Sanchez is way down in Latin America. And Professor Dr. Kiran Godse, he's all over there in India. And actually, it's already quite late for you there. Thank you so much, Prof, to be here with us today. Professor Kiran has written several books on urticaria. He always makes us work in the urticaria group because he has a new idea for, again, a new book. So really look for them as well. Well, let me go on here with the rest of the presentation. Sorry, let me see how I can here get to the next slide. So introduction of mine is 5 minutes. Approach to patients who fail conventional therapy is the first talk, then the treatment options beyond guidelines, and then the management of urticaria. And I think this is also a very important issue. And we in Latin America see this a lot. Also, our colleagues way back in the Middle and Far East, what to do when we have only limited resources. How can we then best treat these difficult urticaria patients? And we hope to have a little bit still spare time for some questions. Well, these are all the countries worldwide that are registered for our webinar today. You can see it's in Europe, it's in Latin America, it's in Australia, it's in China, India, and Far East. It's here, US and Mexico. Is really an absolutely global issue. We have here today Africa, surely, all those colleagues joining in from so many parts of the world. And we can also understand if you just at this moment start your clinic, but you know we always tape the sessions, and on the Urticaria platform, you can find all those taped sessions back. There were very good webinars last year as well. So please feel free and search a little bit further for there if there's other objects and subjects you'd like to listen to. But those are the countries now here just on the list. I already showed them on the world globe. And yeah, sure, we're happy to have always with the webinars. And thanks so much for helping assistance there in the Charité in Berlin, the CME accreditation. So also this time we have CME accreditation. Here it explains you a little bit how you have to do this. I won't waste too much time on this, but please, if you want to get this, we need your feedback. And here you have the QR code to give us some feedback on this webinar. I'll show it again at the very end of the webinar, so everything is under control. Well, yeah, this is me. I'm Professor Désirée Larenas-Linnemann from the Center of Excellence in Asthma and Allergy in Mexico City, Hospital América Sur. Yeah, those are my credentials down there. Maybe in the urticaria, the most important thing is that I chaired the urticaria guidelines from Mexico first, and now I'm one of the co-coordinators always of the global urticaria guidelines of small groups that I sometimes chair. That's something I really am very happy to do. And I'm also a UCARE Center, Center of Excellence in Urticaria. So also joining quite some of the many projects that are going on in the urticaria lovers group. And if you really are an urticaria lover, please take a look at the website again, and try to become a UCARE Center. I also am not a super top high academic center, but we really try to do our best. So don't think you don't fit in this group. Absolutely. If you're thrilled about urticaria, therefore we can find a place for you among us. Well, now coming quickly to the guidelines now. This is what the guidelines tell us, how we have to, the latest guidelines published in 2022, tell us how we should be treating urticaria patients. Now, we already know all about starting with a normal dose of second generation, please no more first generation, second generation antihistamines. If it doesn't do enough, go to quadruple dose. And again, this can only be done with the second generation non-sedating antihistamines. If the patient is not well controlled like this, well, what can we do? Well, we have to add omalizumab, the second step. So in urticaria treatment, chronic urticaria treatment is adding omalizumab. And if there's still not enough improvement, then we go updosing omalizumab, and only after updosing omalizumab and really trying to give the patient here 4 to 6 months, because it sometimes needs a little bit of time to really kick in, especially in these difficult patients, then, well, we might add or change to cyclosporine. More so if you think that this really is more an autoimmune disease, then maybe the cyclosporine could be a little bit better. And then there's other options that have much less evidence behind them. Well, this is more or less what the guidelines tell us. And also the guidelines tell us, well, we always have to reassess the patient and try to use here some official tools. The ACT, I think, is a very simple, validated, very useful tool. It's accessible in many different languages already. And according to where your patient fits in with the ACT, you shall adjust your therapy. So if you have an ACT below 12, therefore this patient is not controlled, and you should be stepping up your therapy. If the patient is like between 12 and 15, it is more or less controlled, and at least you can have to continue your therapy. Maybe you can still optimize a little bit further, trying also to attack eventual triggers. If your patient has 16, which is the complete and the highest score, then you might maybe start thinking of when could you level down one step in the therapy of the patient. So that's what the guidelines tell us. Well, but not everybody fits in there of all my patients. So let's now go to the first talk of Professor Jorge Sanchez, Approach to the Patients Who Fail Conventional Therapy. And then at the very end, we still have time for the questions. Professor Jorge, the stage is yours.
Thank you, Désirée, for your introduction. I want to start telling that this is an honor for me to be here. Now, I'm going to talk a little about the approach to chronic spontaneous urticaria patients who fail with conventional therapy. But I'm going to focus in those interventions, no pharmacotherapy intervention that we can do in this patient. So the first thing that we can ask with this presentation is, what is fail with conventional therapy? Fail with conventional therapy is the same as no control. But what is no control? No control can be defined from different point of view. For example, we can talk of control according with the activity of the disease. We can talk of control about the quality of life. And also we can talk of control according with the the response to pharmacotherapy. So we have different ways that we can talk about control. And this is a very important point because not always we talk about control and the patient understand the same control in the same way that we do. Despite that these three ways of evaluate control have a high correlation, we observe here that the urticaria activity score have a high correlation with the quality of life, and also quality of life have a high correlation with urticaria control test. But nevertheless, the correlation is not perfect. So we observe some patients that have control according one of the scale, the clinical tools, but don't have control according to other type of clinical tools. And this is very important when we are in a clinical appointment in front of a patient, because sometimes happen things like this. I was in front of this patient, and the patient told me that she feel very well, that I was the best doctor that she never seen, so that she was very happy with me, because with antihistamines, she recovered all the activities that she was doing before the urticaria start. Nevertheless, when I make the physical examination, I observed that the patient have more than 50 heavies. So how this patient feels so well if they have more than 50 heavies in the skin? So the answer to this is because for the patient, the most important thing was the quality of life. And with the antihistamine, they have a complete control of the pruritus. Despite don't have control in the hives and in the wheels, the patient have control in the pruritus, so she can do all the things that she wants. But for us as a physician, maybe the activity of the disease is an important point. So we observe that sometimes we have discrepancy with the patient about what his control is. And this is important because if we understand that sometimes we can talking about control in a different way of the patient, maybe we can't say that we have a fail in the treatment, but it's not a fail. It's only that the patient have different point of view of what is important for his control. So the first message that I want to present with this question is that the evaluation of chronic spontaneous urticaria patient must consider the patient opinion. The second question that I think that is important for this first part of the presentation is how good are clinical guidelines? If we observe that the international guidelines of urticaria are very simple, are very easy to understand, because only have three groups of drugs: antihistamines, omalizumab, isaclosprin. That's all. There are the three conventional therapies that we have with these therapies. And despite they are very simple, are very effective, because we observe that most patients have a good clinical control in the quality of life, in the urticaria activity, in the control or in urticaria control test, using this one of these steps. If the patient have control with antihistamine, okay, continue with antihistamine. Or if no, go to omalizumab, or if no, go to cyclosporine. But the three presentations of today are focused not in the patients that are happy with the treatment, are focused in those patients that don't have a good clinical control despite continue each one of these steps. And these patients have a very burden of the disease, because these patients have a lot time loss because don't have control with conventional therapies. As you observe here, if we continue with the challenge period for each one of the therapies recommended by the guidelines, we observe that the patient have to take between 9 to 14 months to evaluate each one of the steps. But in the real life, this time is longer, as there were studies in population from Europe, population from Latin America, and population from Asia has shown us. So this is time that the patient don't have a good clinical control, and this time put in danger the relation between the doctor and the physician, because the patient lost his hope that we can give the correct control of the disease. So we observe that the clinical guidelines are good, but we have a lot of problems for the control. And the patient have to take a lot of time before we can say that the patient have or not control with conventional therapy. So how we can reduce this time? The time to evaluate is one of these steps. One approach to this is to use different prediction models. Prediction model can reduce the time because we can identify in the present what is going to happen with the patient in the future. One of the prediction models that we have working in this moment includes 6 variables that are very easy to have in the first clinical appointment with the patient. and make a calculation about how is the risk of the patient to have or not respond with antihistamines. But in other parts of the world, different prediction models have been developing and focusing the response with omalizumab, or for example, when we can reduce the dose of the treatment, or maybe in what patient is going to have a remission or a persistent disease after 5 years. All these models need to external validation, but maybe in the future could help us to reduce the time of evaluation of each one of the therapies and reduce the time of the patient with this time lost. So what can we do with patients that don't respond with conventional therapy? As I said before, I'm going to talk about no pharmacotherapy intervention that we can do with this patient. David going to talk a little about what other intervention, pharmacotherapy intervention we can do in the future, in the present. But in this moment, I want to focus that what patient not respond with conventional therapy. Maybe those patients have a different phenotype, a phenotype that have a refractory response with antihistamines, omalizumab, and cyclosporine. Nevertheless, sometimes the non-responding patients have a more simple reasons to not respond with pharmacotherapy. And with some modifiable factors, we can introduce a good control of the disease in those patients. So let's talk about 4 possible modifiable factors that we can do in the clinical appointments for improve the control of the disease in the patient. The first one is that when we are in front of a patient that not respond with antihistamines, cyclosporine, or omalizumab, we have to think, it is really chronic spontaneous urticaria? Maybe most of the people that are listening to this presentation are allergists and dermatologists. And that was the group of the specialists that for one study collaborate, including patients with urticaria. In this study, we included 948 patients with urticaria after analysis of dermatologists make the diagnostic of urticaria. Nevertheless, when we did the follow-up of the patient, we have to exclude 222 patients because those patients don't have chronic spontaneous urticaria. Some patients have idiopathic pruritus, other patients have atopic dermatitis, because the patient, when we ask in the clinical appointment, do you have a hive? The patient can tell us, yes, I have hive. But the patient don't know sometimes what is a hive or don't understand hive as we do. So it's necessary to show photographs to the patient that he observed the skin injuries, and in that way, he can identify more correctly if they have these skin injuries or not. Second, we have to ask to the patient to make in the next clinical appointment with photograph of himself when they have the presentation of the symptoms. In that way, we can observe those patients that really have chronic spontaneous urticaria and those patients that not, because maybe the fair treatment, the fair of the treatment that we offer is because it are not focused in the disease, in the correct disease. The second point that we have to take in consideration is that patients with urticaria have a lot of comorbidities. Some TH1 comorbidities, some TH2 comorbidities, some local skin comorbidities, and some systemic comorbidities. All these comorbidities in patients with chronic spontaneous urticaria sometimes can produce symptoms similar to hives, similar to angioedema, and may produce pruritus. So in those patients, it's very difficult to identify if the patient don't have control of the pruritus or the angioedema because don't have control of the chronic spontaneous urticaria, or maybe it's for the comorbidity. So we need to try the patient in a holistic way. We have to try all the comorbidities in this patient to have a correct identification of what patient don't have control of the urticaria or maybe have control of the urticaria and not control of the comorbidities. The third point that we have to take in consideration when we are in front of a patient with not responding to conventional therapy is that sometimes the patient have a good control of the disease with antihistamine, with omalizumab or cyclosporine, but the patient suspend the therapy because they have adverse events. And that is logical and is nice, is a good thing to weigh the things. But sometimes this adverse event can have a different approach. For example, in those patients that have antihistamine sedation, if we introduce the antihistamines in the night, maybe the patient can tolerate in a better way the sedation, and we avoid that this patient have to go to more expensive therapies like omalizumab. Or, for example, with omalizumab, sometimes the patient manifests pain in the local skin point that the application is done. But when we change the skin application position, we can observe that the patient tolerates better the omalizumab. So it's important to know what is the adverse event that the patient suspend the treatment and why. And we have to ask for this because patients sometimes say, no, this pharmacotherapy is not good for me because I don't have control. But they are confusing what is control, clinical control, what is are confusing with what is adverse events. So we have to ask to the patient why they suspend the therapy when they do it. And finally, we need to know how good is the adherence to our patient. Some patients suspend the therapy because they forgot. They say, this treatment is not good for me. I don't see control, but the patient don't take the antihistamine every day, only when they remember or only when they have heavies. So in that case, the patient maybe don't have a good clinical control because there is no adherence to the schedule of the therapy. So for this, different strategies can be done. First, we have to explain to the patient how the pharmacotherapy works. In that way, the patient, if know that they need the use of the therapy according to what is scheduled, is more possible that the patient continue with that scheme. For other part, we can use different apps. For example, cruise control. Cruise control makes some alerts, reminders to the patient that can introduce a way that the patient don't forget as easy the use of the different therapies that we are talking about. So there are two different ways to reduce the adherence. Another important point is that some patients suspend therapy because they have fears of the adverse event of the therapy. For example, some patients, they say, 4 antihistamine per day is a lot, so I'm going to take only 1 or only 2. We have to ask to the patient and explain that if we tell that the patient needs 4 antihistamine, is because he needs and the risk of the adverse event is low. If we take all these modifiable factors, we observe that we have a lot of things that we can do with patients with no response with conventional therapy. But how impact this in the clinical practice? We did a retrospective study, including more than 1,345 patients with urticaria and we evaluate the response with each one of the steps recommended with the guidelines. We observed that a lot of patients don't have a good clinical control with conventional therapies. But after the modification of these factors, these patients have the patient without response have a reduction. The group of patients without response have a significant reduction, and patient with a good response was high. So these interventions are no pharmacotherapy intervention, are easy, are not expensive, and maybe can improve the control of the patient with chronic spontaneous urticaria who fail with conventional therapy. So finally, some practical measures. The evaluation of chronic spontaneous urticaria patient must be multifactorial, considering the patient opinion. When a patient failed with conventional therapy, different factors must be evaluated: preference, adherence, correct way of use, comorbidities. Controlling of the life factors can reduce therapeutic failure, the introduction of more expensive therapies, and the patient time without disease control. Okay, I finished with with interventions, no pharmacological intervention. Now, David, continue with pharmacotherapy intervention that we can do in this patient. Thank you for your attention.
Okay. So I'm going to be talking a little bit about beyond the guidelines here. It's a real pleasure to be speaking to everybody. I don't have any disclosures. And I think before we get into beyond the guidelines, I think it's important to discuss a little bit about the guidelines and some of the nuances of that. Step therapy in chronic urticaria. Dr. Larenas-Linnemann already kind of went through this, but I want to dig into this just a little bit more. So on the left-hand side, you've already seen this stepwise therapy, starting out with second-generation antihistamines, increasing the dose, then going on to omalizumab, and then lastly, cyclosporin. On the right-hand side are the US guidelines, which are outdated. Some of the main differences are there's some additional options to consider before going to omalizumab, and then some additional options other than cyclosporin. So I think every international guideline recommends starting with second-generation antihistamines and going up fourfold, and I don't think there's really a lot of controversy behind that. Interestingly, if you look at the evidence behind the fourfold increases with second-generation antihistamines, it's not quite as robust as we'd like it to be, and that doesn't mean that it doesn't work. It just means that the studies haven't really been that well done. Now, this was a question that came up in the most recent international guidelines about, should we add additional second-generation antihistamines at the same time? And the consensus was not to do that. However, I think there are some patients who may respond. So this was a paper from the group in the Netherlands who looked at patients who were treated with standard doses of a variety of antihistamines, and then they went up to fourfold. And if they didn't respond to fourfold of one antihistamine, they added another antihistamine and increased that up to fourfold.
Hola, Javier, perdóname que te llamé, pero era porque me diste autorización de llamarte.
So what they found was that about 54% of patients failed the single fourfold dose H1 antihistamine. And then when they updosed to two separate antihistamines up to fourfold each, they had another almost 50% of patients improve. So this is another simple step that one can consider in patients who are refractory to single-dose, high-dose antihistamines. Well, the next step is if you fail antihistamines, according to the guidelines, is to add omalizumab. And there are a number of systematic reviews looking at omalizumab in chronic spontaneous urticaria. This was one published by the EACCME group, and they found 10 randomized controlled trials. This is only looking at licensed doses of omalizumab, and we'll talk about that in a moment. And they had looked at this with a grade analysis approach. And what you see is that there was moderate to high level evidence for improvement in urticaria activity score, itch severity, quality of life, reduction in rescue medications, etc. So we know that this is a well-studied medication. One of the other findings from this meta-analysis was that if you look at complete responders, those who have absolutely no hives, you saw then about 43% of patients who were treated with standard doses of omalizumab versus 9% usual care, so dramatically different. Now, one of the areas of interest is how do we predict responses to omalizumab? And probably the most common thing that has been looked at have been total IgE levels. So this is a recent systematic review and meta-analysis of 10 different studies looking at how well IgE levels predict response. And what we're looking at here is non-responders to omalizumab versus complete or partial responders. And complete responders and partial responders tended to have higher IgE levels than the non-responders. Interestingly, if you looked at patients who had early clinical response versus late clinical response, early clinical responders also tended to have higher IgE levels. However, there are some issues in terms of applying this practically. First of all, what is the minimum or maximum level of IgE for predicting response? That's really not clear yet. Also, most of these studies are not randomized. They're relatively small sample sizes, and most of the studies are from Europe, and so generalizability throughout the world is less clear. So I do think this is an area of promise, but there's still more studies that really need to be utilized before we can really apply this routinely in our clinical practice. Well, what happens when omalizumab fails at the standard dosing? Well, according to the international guidelines, you can then increase the dose to maximum of 600 milligrams or reduce the frequency or perhaps do both. Unfortunately, there are no randomized control studies looking at this, but there are a number of different retrospective studies looking at how effective this is. This is just one. This is an older study from a group in Israel looking at patients who failed antihistamines and were placed on omalizumab. And you can see about 2/3 of patients were controlled. and about 2/3 were either slightly improved or not improved at all. And what they then did was they increased the dose. So I just want to focus on the group that was treated with the standard 300 milligram dose. So 230 patients, 152 were well responders, and about a third didn't respond, and their dose was increased to 450 milligrams per month. And you can see that most of these patients actually had a significant benefit. Now, there still were some that failed that. Here's another paper from a group in the Netherlands looking at 166 patients treated with omalizumab. 122 were well controlled on the 300 milligram dose, but there were about 44 patients who were not well controlled. And so this is looking at 300 milligram standard dosing. After that time period, they really didn't have much improvement in their UAS7. When they went to either 450 or 600, they had significant improvement. Now, in this group, they had 9 patients that were treated with 600 milligrams every 2 to 3 weeks, and none of them improved. So this does raise the question about whether there is some plateau above which giving more omalizumab really is not effective. But in their study, about 61% improved with updosing overall. Now, what about just changing the frequency? So this is a small case series from the group in Istanbul that took the standard 300 milligram dose and just split it to 150 every 2 weeks in 6 patients. And what they found was that all these patients were controlled on every 2-week dosing. The nice thing about this is that you don't necessarily have to, and at least in the US, you have to battle with the insurance company to get approval for higher doses. And here you're just using the standard dose, just splitting it more frequently. And this can be particularly effective for patients who have kind of a wear-off effect, where that with the week before their omalizumab dosing, they're starting to break out in hives. This can be an effective strategy. This is another paper that looked at the idea that omalizumab concentrations, number one, vary quite a bit and may be affected by body mass index. So the higher the body mass index, those patients who had more obesity actually had lower omalizumab concentrations, and that was associated with worse CSU outcomes. Now, as we know, with asthma, omalizumab is dosed according to IgE levels and weight, but in urticaria, sort of this one size fits all, and perhaps that may not be appropriate. So in your more obese patients, that's something to consider, would be perhaps increasing the dosage. Now, what about other forms of urticaria? What about inducible urticaria? Is omalizumab effective there? This is a systematic review, and anything in color is showing trials showing improvement. So this is symptomatic dermographism, this is cold urticaria, delayed pressure urticaria, solar urticaria, et cetera. So it does appear effective in inducible urticarias. With cholinergic urticaria, there was a randomized controlled trial that looked at 4 months of therapy, and they did not see any improvement. When they went into open label extension, they did see improvement. So for at least for cholinergic urticaria, it may require at least a 6-month trial to really see improvement. And that's something that we've seen in our clinic as well. What about angioedema? We know that angioedema is now classified as a form of urticaria, and can omalizumab be effective for angioedema? So this is data from the EXACT trial. And what you see is the angioedema scores also improve with omalizumab, just like urticaria did. Now, we know that not everybody who gets put on omalizumab will improve, and even at higher doses, you can see failures. This is looking at observational study, open label extension out to 6 months, and you can see 73% of patients had control. That means that almost 30% did not have control. So the international guidelines then recommend going to cyclosporin. And that's not unreasonable. I want to share this study from the previous presenter, Dr. Sanchez, which I think is a really interesting paper looking at patients who were treated, who failed antihistamines, were treated either with omalizumab or cyclosporin for a period of 4 months. And then they were, if they failed that, they were crossed over to the other thing. So if they were on cyclosporin, they went to omalizumab, omalizumab to cyclosporin. And many patients did have improvement. However, there were 21 patients who failed both omalizumab and cyclosporin. And what they then did was combine the two. So combination of omalizumab and cyclosporin. Now, the interesting thing here is that if you look at 2 months, only one patient got better. But over time, you started to see more and more people get better. And by the end of this 6-month period, about 3/4 of patients had responded to that combination therapy. There were still some refractory patients, but I think the message here is in these refractory patients with combination therapy, you do need to wait a little bit longer to see that response. I think that's an important point from this really important study. Now, there are a number of alternative therapies for chronic urticaria, and overall, the evidence for these is fairly weak. Few of them have had randomized placebo-controlled studies, and when they are, these are usually relatively small numbers of participants. Now, that doesn't mean you can't use them. It just means that this is what the evidence shows. There's a number of these different therapies that are available, and Professor Godse is going to be talking about these. Honestly, in the U.S., which is, we have, we're not resource limited, but we still use many of these therapies as well. So these are certainly less expensive than biologic therapies. Most of these do require some laboratory monitoring, so that's a difference. I do want to point out a couple things, and that is colchicine and methotrexate have both been studied in randomized controlled trials, and they were found not to be effective. So there are some things that we think are probably not particularly effective, and the other ones, they may be useful for certain patients. Now, the biggest concern when using alternative therapies is that of adverse effects. And this was a paper that we published a number of years ago looking at our experience with some of these things like dapsone, sulfasalazine, hydroxychloroquine, tacrolimus, mycophenolate, cyclosporin, etc. And yes, you do see some typical adverse effects. Dapsone causes a predictable drop in hemoglobin. GI symptoms and headaches are common with the other agents. But what I want to really point out is that we didn't see a single permanent complication from these medications. And in fact, it was quite rare that patients had to stop the medication because of adverse effects. Sometimes you had to reduce the dose, but serious complications are rare, even with these immunosuppressant or anti-inflammatory medications. Now, the things that I most commonly use nowadays in the era of omalizumab failures, some people would consider doxepin as alternative agent. I tend to prefer tacrolimus over cyclosporin. I think there's less and different adverse effects with it, mycophenolate, and in particularly refractory patients, sirolimus. Now, what about other biologics for CSU? This is an area that's of extreme interest, and there are some things that are currently available for other therapies. So anti-IL-5 agents have been looked at. Dupilumab, as you know, is seeking an indication for chronic spontaneous urticaria. And in the US, I know that there are a number of people who are using it off-label to treat CSU even today. Probably the most exciting next thing is the BTK inhibitors, such as remibrutinib, which will likely be seeking an indication later this year, and other agents are out there as well. So in conclusion, antihistamines are effective in many patients. Higher doses or multiple agents may be additive. Omalizumab is effective in most patients with antihistamine refractory CSU, many physical urticarias and angioedema, but dose adjustments may be required in those who fail, and in obese patients, you can consider increasing the dose as well. Alternative therapies have less evidence, but can be safely used in refractory patients, and Dr. Godse is going to be talking about that in much more detail next. And I think in the future, it's really unclear which biologic is going to be most effective in patients who fail omalizumab. So thank you for your attention. I will turn it over to Professor Godse.
Yeah, thank you for that wonderful presentation. Now we go for management of urticaria in resource-poor settings. So what I mean by resource-poor setting is, countries, they lack financial means to cover the cost associated with infrastructure, health, or the trained professionals. So typically, patient pays from his pocket for his urticaria, and you can understand this is with 1.42 billion Indian population with just 10,000 dermatologists and more than 100,000 primary care physicians. So urticaria India specific guidelines were started in 2011 and now the latest one is 2023. This is in taking into consideration India's patient population and what India specific treatment we do. So typically our guidelines clearly state that urticaria lasting more than 24 hours, think of vascularization biopsy. And angioedema without wheals, think of hereditary angioedema. These are the two things we tell our primary care physicians as well as dermatologists. And urticaria, we all know, is acute and chronic. So acute is 6 weeks and chronic is more than 6 weeks. It is more for the general population, general doctors. Well, Jamin, just to touching about the symptomatic dermographism, we all know there is a writing on the skin and itching and sensation. Now, typically, a Frick test was devised in Europe and it's easily available. But again, the cost prevented us from taking it. So we did our Indian own version of a Frick test, a skin rhetometer, which also works equally well to understand the severity of dermographism. Well, emerging endotypes are known, autoallergic and autoimmune. We all know that autoimmune is type 2B and autoallergic is type 1. And this will clearly say that Ig anti-self is autoantigen, that is what autoallergic and which is supposed to be a predominant urticaria as on today. And autoimmune type 2B is relatively less common and there are various other pathways which are yet to be evaluated. So just to tell you that autoallergic and autoimmune, our guidelines clearly states that you do Ig and other tests to find out whether patient is autoallergic or autoimmune. And just normal or high Ig levels are there in autoallergic and low in autoimmune. And typically disease is less severe in autoallergic and high or more severe in autoimmune. And the test is specifically, unfortunately, we don't have auto Ig test as till today to detect type 1 or autoallergy. We have got auto IgG antibody test like ASST or ELISA or basophil histamine release assay. So we always tell that at the end of 1 year, 50% patient resolve. That is the biggest golden line for urticaria. Half of patients are going to recover at the end of 1 year. So patient must take treatment. And this is for all our dermatology. We tell that please give treatment till it goes. And typically at the end of 1 year, 50% will resolve. Otherwise, it can go up to 5 to 20 years. And all the patients, these are the patients which can keep on coming to dermatologists. Typically, in India, patient first go to primary care physicians. He gives antihistaminic. If it doesn't respond, then he goes to a dermatologist. So we see the patient which are severe disease with longer duration, females more than age 50, those with concurrent angioedema or inducible urticaria, BMI more than 32, smokers, NSAID, hypersensitivity, associated features like asthma, rhinitis, or polypharmacy. These are the people will take longer time to respond and only updosing may not help and something beyond is required. So these are the EACCME guidelines. We have just seen that, but please remember a single tablet of antihistaminics only controls 50% of patients. So typically half of these patients do come to a dermatologist or to a higher center to treat. And we have options like omalizumab and cyclosporine, which have got best evidence. But unfortunately, every patient can't afford to use these ones. So what we do is something else. So I'm going to tell you that. So these are the Indian guidelines. These are actually more considering patient's pocket also. So typically antihistaminic fourfold is there, but we still keep, and Dr. Khan also reported that a combination sometimes works. So we do give 2 different antihistaminics, and ranitidine and montelukast has a place in some of the patients. And third line option is after omalizumab and cyclosporine is methotrexate, dapsone, and autoserum therapy. They works in selected number of patients. So again, options are many for patients apart from the basic option of a non-sedating antihistamine, that is a first line therapy. So omalizumab, it works wonders as long as you prevents angioedema, improves quality of life, and suitable for long term. But in India, we have a biosimilar available of omalizumab, which is relatively economical, so some patients do afford it. We all know that everybody do not respond to omalizumab. Those with BMI more than 30, aggravation of CSU after omalizumab, low Ig, basopenia, high D dimer, positive anti-TPO, this patient will not respond. So as already reported, you can always combine with cyclosporine, but we combine with methotrexate or hydroxychloroquine also to enhance the response of omalizumab. Well, cyclosporine, again, every patient is still a costly drug and immunosuppressants, but it works as long as you give typically 2 to 3 mg per kg dose. But again, in India, we give low dose cyclosporine, just about 1 to 1.5 mg kg to reduce the cost of cyclosporine, and we do get good response. Obviously, you need to check CBC, creatinine, and blood pressure. So workup wise, we'll just tell you basic investigation which we insist that patient must do in Indian setting, which are not very costly. Actually, it is actually streamlined. Now these four are the one which we tell the patients to do it typically: CBC, CRP, total IG, IgG, anti-TPO, and the optional are sugar, thyroid, urine, and stool. Stool due to worms, again India, some specific areas we do see, and a urine infection. We strongly recommend against skin allergy testing in patient with CU, and we recommend against diet elimination routinely in patient with CU. Typically, in Indian setting, few of these things are not possible, and sometimes patients stops eating everything, and his weight loss is a major problem there. So we all know IG is a best indicator. High total IG indicates autoimmune type of urticaria, and low IG indicates low IG is a type 2, that is autoimmune urticaria, and high IG is autoallergic urticaria. So typically, high IG omalizumab is the drug of choice, and low IG cyclosporine is a drug of choice. So this is a valuable marker, and it's not very costly. So we do it routinely in our patients. Again, the CRP is an effective marker of inflammation. High CRP level is indicator of a non-responder to antihistamines. And complete blood count in a 5-part cell differential gives us an idea about basopenia. It is again most of the basophils are recruited in the skin, so blood you see less and less basophils. It's a marker of antihistaminic resistant CSU. And eosinopenia again is a type 2 autoimmune disease and poor response to treatment. So these two are an indicator. In a simple CBC, we can come to the conclusion. And last important test is anti-TPO IgG type, which is available in India. Again, a positive IgG, anti-TPO, and low total IgE are the best surrogate marker for autoimmunity. By doing this test, we can come to reasonable conclusion. But what next? Every patient can't afford cyclosporine or omalizumab in India. Antihistaminics are available easily. We have got double strength of almost all the antihistaminics available. But what next after 4 tablets? So these are the options we use: Montelukast, ranitidine, methotrexate, dapsone, autoserum therapy, doxepin, and last 2 you might be wondering is oral mini-pulse steroids and tofacitinib. These are the new things in India. So our guidelines clearly states condition where a short course of oral corticosteroid may be required, typically in those patients with flare of urticaria with severe angioedema, flare of urticaria with breathlessness, a severe flare of urticaria where patient we can't start omalizumab or cyclosporine. Again, in pregnancy, updosing is we don't advise. So again, a short course of steroid is required, and severe acute urticaria suspected to be caused by drugs or infection is ruled out. You can always use a short course of oral steroids. Now, this is something new. When you say urticaria is autoimmune, so most of the autoimmune diseases in India, to reduce the side effects of steroids and give maximum effect, mini-pulse steroid therapy is used typically for majority of autoimmune disease, say it lichen planus or alopecia areata or vitiligo. So typically, methylprednisolone is which we use 16 mg on Saturday, Sunday, along after breakfast, along with levocetirizine. Typically, we do see less side effects when you give twice a week and steroids. And obviously, few patients will get weight gain or gastric pain, but a reliable approach, an economical approach to treatment of chronic urticaria. We did publish a small study long way back, but it is still a safer option who cannot afford a second and third line therapy. Montelukast, well, we do use and we do believe it is useful in respiratory allergies and in NSAID-induced urticaria. H2 antihistaminics, less evidence. They were there in our guidelines 10 years back, and I do still feel that ranitidine 150 mg twice a day is safe and economical approach, or famotidine can be used because there are H2 receptors in the skin also. So some people do respond to ranitidine. So for an Indian patient, this is what our 7-tablet formula for CSU. So physicians who do not want to think or find out, you give these 7 tablets and your 70% of urticaria patients will come under control. So typically 2 tablets of bilastine or fexofenadine in the morning because of low sedation potential, and 2 tablets of levocetirizine or loratadine in the evening, again due to little sedation potential, along with 2 tablets of H2 antihistamines and 1 tablet of Montelukast. So typically these 7 tablets does work wonder in most of the patient. 2/3 of patients do respond to this therapy, and many of our primary care physicians do use it and get a control. But who can't, again, methotrexate is an option, 10 to 15 mg with folic acid. Again, there are conflicting reports of India, and meta-analysis also has shown this thing, but it does work. It works slowly. Typically, it doesn't work as fast as cyclosporine, and results are seen only after 4 to 6 weeks. And typically, then it's not great. Some patients just refuse to respond to this therapy. Mycophenolate mofetil, again, an anti-metabolite, 1 to 2 gram per day, but it is not often the first choice. The methotrexate is the first choice, being it's economical. Well, dapsone is useful, 50 to 100 mg per day in vasculitis and delayed pressure urticaria. We definitely use it. Again, in some urticaria patients where 4 tablets afterwards, dapsone may be tried. Again, in India, doctors know how to use this molecule because of the part of anti-leprosy treatment. Dapsone is an important component. Autoserum therapy, it's a poor man's biologic, intramuscular subcutaneous injection of autologous blood or serum, basically to desensitize the pro-urticaria factors in patient serum. 2 to 3 cc every week for 9 weeks. 1/3 patient do respond, and our Indian patient love injections. So typically after 4 dose, this option is sometimes we use in India, and there are more than 20 publications from India which says that it has got efficacy in most of them, but obviously it is not a great molecule. Well, the last molecule which we use it is tofacitinib. Now you must be wondering why. It's a JAK inhibitor, because in India the generic version is available in India, and we all know that tofacitinib is a JAK inhibitor which suppresses the intracellular signaling of several important cytokines, and it is involved in the inflammatory cascade in addition to blocking of JAK1 and JAK3, and it is being shown to downregulate the inflammatory process linked with the mast cell. So although it's not FDA approved, it's a generic version which we use it as a immunosuppressant after 4-fold drug, and it does give good results, and there are a few publications which have been published. Again, important is to rule out the infection. Tuberculosis is the most common in India, so we just try to rule out by doing a IGRA test and X-ray test also sometimes, because tuberculosis is one thing which we are afraid about, but dose is 5 mg twice a day. And typically we see the results by the end of 2 to 4 weeks in the form of reduction in hives. Obviously, we continue the 4-fold tablets of antihistamines. And again, you need to do some basic investigation repeatedly, like CBC, lipids, and LFT. And side effects are recurrent infections, or some people are prone to, typically in India. But still, it's a handy drug to us when a patient can't afford an immunosuppressant, a cyclosporine or omalizumab. This being an economical version, people do try to use it in India. So summarizing, a second generation antihistaminics with updosing is the first line therapy, omalizumab with updosing is second line, and cyclosporine is the third line based on the evidence. But other economic therapies are available which can be used to reduce the cost of the burden of the disease to the patient, and which again more research is needed for these therapies because still the evidence is weak for these therapies. I think that's all from my side. Thank you very much for patient listening.
Yeah, thank you so much, Dr. Godse. Thank you to all 3 of our speakers, and it leaves us for some 5 minutes for Q&A. I've been looking here to the chat, and I'd like to start on at once. Maybe the first question to Dr. Sanchez. What about the triggering factors, and here particularly the emotional part? There was some question about psychotherapy even. Could you elaborate a little bit further on that?
Thank you, Désirée, for the question. I think that that is a very important point, but in this moment, I don't know if this have the same meaning in Spanish than in English, but we don't know if it was first the egg or the chicken, because the emotional part is important, but if you have urticaria, you have an emotional, even you have mental health disorders, but we don't know if the mental health disorder produce the pruritus, or you have pruritus and mental disorder as a secondary effect. So the relation exists, that is clear. A lot of studies demonstrate that patients with chronic spontaneous urticaria have 3 times more risk of mental health disorders like anxiety and depression than patients that don't have this disease. But we don't know who is first. And if we don't know what is first, we don't know what have to treat first. If we have the anxiety and we can try the anxiety and reduce the urticaria, nice, because in that way you have an additional therapy for managing this patient. But if the problem is secondary of the urticaria, maybe you can reduce the anxiety with some drugs, but the urticaria is going on. It's going to continue. So we need to understand better what is the relationship between these 2 factors that exist, but we don't know what is first. But in a practical point of view, it's true that if you control the mental disorder, the anxiety, the depression, the patient feel better and confront in a better way the disease, because they know, understand, and comprehend better the problem and know the dimension that they really have.
Yeah, thank you so much. And definitely, and finally, at the end, it's all the same. It's which is the cause. But if they are stuck there with the chronic urticaria, uncontrolled and anxious and desperate about it, I think you should treat both. And I think definitely it's very important to pay attention also to the emotional part. And it also makes patients oftentimes understand better now, because again my wheel, this is so bad. No, you feel this bad and then you get more wheels. So really, and what in my opinion also very important, some doctors, they say, okay, now it's only urticaria, but this can give you swelling of the lips and it can go inside. I don't know. So mixing it up with anaphylaxis. And I think it's always very reassuring to my patients. Anaphylaxis is one thing, urticaria is completely another thing. So you won't go from one to the other, putting your life in danger. I think that's also a very important message we should give. I've heard a question, and I'd like this to Dr. David Khan about the antibodies. Now, I've been discussing a little bit in the chat as well. Antibodies to omalizumab, that's one. And the other one was the updosing of 2 different antihistamines. I understand you gave one 4 times and the other 4 times as well. Or is it twice?
Yeah. So, with the neutralizing antibodies, I think it's something that people have wondered about, because you'll definitely see patients who respond really nicely to omalizumab and then they lose control. And the question is, have they developed these neutralizing antibodies? There was a paper in Practice that looked at development of neutralizing antibodies across a number of different biologics. And interestingly, omalizumab had the least number of but this was not specific to urticaria patients, and I'm unaware of anyone who's looked at that subset of patients who are well controlled and lose control to see if they develop neutralizing antibodies. But many of these patients can be rescued with therapies that are used, like in Crohn's or whatever, that where they do develop neutralizing, you can treat them with an immunosuppressant, and that's what we have done. You put them on cyclosporin, tacrolimus, or whatever, regain control, and then you can taper off that. So it seems like they are there, but there's really not evidence, I think, for that. But it's also because maybe no one's really looked at particularly at that subset. Regarding the paper where they were doing the double dosing, it was 4-fold of one and 4-fold of another. So they really went up. It's interesting. So it would be, I guess that would be 11 tablets with Dr. Godse. You would have to go from 7 to 11. A real handful.
Yeah, definitely. Then I'd like to go now to Dr. Godse about 2 points here. The anti-H2. If you could comment a little bit further on that, and then here, for us in Mexico, for example, we don't have ranitidine anymore. It's been taken off the market, but we have famotidine. So we do. It's a 1 tablet a day of 40 milligrams. But I agree. In low budget patients, I do your mixed 7 tablet minus 6. Yeah.
So, see, we do believe it works there. It was there in 2008 guidelines, 2012 guidelines. Again, the data is missing, and again, companies are not interested. Ranitidine is out of market, but famotidine does work, because I do believe that H2 receptors are there everywhere, not only in the stomach but on the skin also. So some patients do respond, and especially typically they will tell you that ranitidine gives them addition of this is wonderful result. So we do use, especially somebody who can't afford a second line therapy.
Yeah, and then the autologous serum. That's my last question to you. What's the data there? I know some colleagues in Latin America do it as well, but they're the old ones.
Yeah, so typically auto serum therapy is being used typically who can't afford, and injections are most preferred in Indian patients. Indian patients love injection. So they do come, so it may have some placebo effect also, but typically 1/3 patient do respond, and we do use it routinely for our patients after fourfold. When they don't respond, this is the option. Again, in a select number of patients, we do use it.
Well, okay. Thank you very much. Thank you very much to the panel. And then the very last part now, the last minutes, because we just went over the hour of the webinar. Well, we want to thank our sponsors. Shirley, thank very much your time to our faculty, and also Shirley to you over there, wherever in the world, being together, joining now with us, and also you who will maybe listen to this a little bit later. We know quite some of you do that. I just wanted to tell you there's also another nice, interesting website. It's the 31st of this month, the last day of the month, again, by the UCARE groups. So please, again, take a look at the website if you'd like to join us in that. And here's a discussion of case reports. So now we also go into angioedema with this group of the UCARE LevelUp. And this is, if you want to stay connected with us, also social media, websites. Here, this QR brings you directly to our UCARE website. So this one, really scan it in or take a picture. And well, we hope to have many more of you on board. Also, trying to be an active UCARE center. And well, again, here now, thank you very much for your attention this morning, afternoon, or evening, wherever you are in the world. Thank you so much.